recently, the Duke Global Health Institute and the Duke Cancer Institute joined forces to create a global cancer program. We were especially fortunate to recruit Dr. Nelson Chao to direct the Global Cancer Program. And today, Nelson is going to come and tell us about a cancer care partnership in Mwanza, Tanzania. Now, the personal connection with Nelson is that he and I were college classmates. Now, he's really worried what I'm going to say next. But we were college classmates together, and Nelson has been incredibly supportive of our efforts to develop capacity in cancer care, and he has been to visit with us several times at KCMC. So, welcome, Nelson.
Thanks, John. Thank you for the invitation. I'm glad you stopped where you stopped. So it's been really a pretty amazing day going from the basic science to networks, and then I'm going to talk about something really completely different, but this is also John's fault since he got me into this. So I'm going to talk about global oncology, which I call Go Duke. And the facts of this is really pretty plain. They are 7 million cancer deaths, of which 70% occur in low to middle income countries. And the prediction is by 2013, these low to middle income countries will bear the major brunt of 27 million cases with 17 million cancer deaths. I mean, these are, the problem with numbers like this is they're just statistics because they're somewhat hard to understand. And in these places, 80% of the disability adjusted years of life is lost to cancer. So these are huge unperceived costs of inaction. And I think there was a nice meeting at the Harvard School of Public Health where they called it Closing the Cancer Divide. And the bottom line is that much can and much should be done. If you look at the actual data, we're over here, and these are all different kinds of cancer, and it doesn't really matter that much which these are, but if you just look where we are in these high-income countries up to the low-income countries up here, you can see that the ratio of mortality to the incidence is quite high in these low to middle income countries. So in those countries, if you get cancer, you're very likely going to die of it. So we do need to start working on this. There's a huge humanitarian need. Many of these deaths could be averted with early detection and treatment, especially in kids. We need palliation, so they're not curable. At least we can adequately palliate them. And so in many of these places, there's no morphine in the country because of concerns of addiction. There are prevention strategies that we could pull up, community engagement, which is really important. Maybe this is where networks could really help. There are treatment services which don't exist: pathology, radiology, pharmacy, chemotherapy, surgery, radiation therapy. And so I'm going to go over this a little bit. And actually, cancer care, unfortunately, is pretty complicated to implement. And these are terrible iniquities because 80% of these disability-adjusted life years lost worldwide to cancer are in these low to middle-income countries. And they only have about 5% of the resources. So in Africa, for example, in sub-Saharan Africa, it's 0.2% of global cancer medical costs compared to 1% of global spending on health, 6.4 new cancer cases, and 15% of the global population. So it's feasible and effective, so we could do a lot without the latest and most expensive technologies. The low-cost services can be beneficial, even in wealthy countries, so they're actually one of the things I think that might be quite interesting is to learn from best practices in some of these areas that we could bring it back here. HIV and TB experience demonstrates that these complex diseases can be cared for in these countries. Bulk purchases certainly bring the cost down of the drugs, and effective diagnosis and treatment can be delivered even in rural areas. So by far, I think the most preventable cancers are around tobacco cessation. So we don't see tobacco ads anymore, but if you go to these low to middle income countries, you see huge billboards for different tobacco products. So that would make a big impact. HPV, of course, would be a huge impact with the vaccine and certainly screening. And hepatitis infections as well. Again, new hepatitis drug on the market, as well as the ability to prevent some of the infectious agents. So early detection and treatment, certainly cervical screening has made a huge difference in women in many areas of the world. Breast cancer screening, probably in these areas. I don't know how well, breast cancer screening is still a hot topic in this country. Colorectal screening, and for diseases where there are simple treatments, although expensive, things like chronic myelogenous leukemia, which have targeted therapies, picking up some of these cases could make a huge difference for these patients. There are many diseases which we see there that can be treated with systemic treatment. So Burkitt's is probably the poster child for Africa, where the disease can be cured. Other lymphomas, testicular cancer, acute lymphoblastic leukemia can be treated. Soft tissue sarcomas, osteosarcoma, and as I mentioned, CML. So it is complicated. We need a lot. I think we need to start, obviously, with research and the dollars for research and dollars for some of these therapies, but it's a sense of lots of different pieces need to fall together for cancer care. It is not so simple because there are a lot of moving pieces. So you have prevention, diagnosis, treatment, palliative care. You have education of not only the healthcare providers, but education of the population. You have survivorship issues, and you have the issues of incidence, because tumor registries don't really exist, and they can't exist until you have pathology available. So it's sort of a difficult place to know where to start. There are some things that we can do, though. I think telepathology, with most places having available internet, is an area that we're interested in. Virtual tumor boards, so the ability to present a case and discuss potential therapies can be done. Case-based seminars can be done. We certainly have started with visiting faculty, visiting students, visiting nurses. There's potential private-public partnerships, and then this issue of twinning, which is one medical institution in some of these countries tied back to a medical center in this country or in Europe or Canada. So we are going with 3 selected demonstration projects. I call them Leading with Care, which is, I'll show you what we're doing with Bugando. Leading with Education, I'll show you a little bit of what we're doing with the Tata Medical Center in Calcutta, primarily a South-to-South exchange, and then Leading with Research with a cancer center in Barretos, which is in Brazil, in São Paulo, Brazil. And the plan is to try to do diagonal healthcare systems. So take what's available and try to build upon what already exists and to try to connect to the infrastructure that is available at the time. So Mwanza sits on Lake Victoria in Tanzania. Moshi's like right here next to Arusha. And the Tata Medical Center is in Calcutta in the Bay of Bengal area. If you walk to this Tata Medical Center, it looks like a Genentech campus. It's beautiful sandstone and metal and glass. And then Barretos is in the interior of São Paulo. This is São Paulo State. Here's São Paulo, the city, and it's about 4 to 5 hours drive. It's a huge complex, and it is really remarkable that this place sees about 30,000 new cancer cases a year. Duke sees about 6. They see about 500,000 return visits. The care is completely free, food's free, housing's free, and the level of care is really remarkable. They have PET scans, CT scans, they have the latest radiotherapy machines. And this is Bugando. So they have built a cancer center, and this is really pretty remarkable for places in East Africa. This is a 2-story building. There's a generator, which you absolutely have to have if you're going to have the center. Here is the bottom floor. These are the gantries for the 2 linear accelerators, which are supposed supposed to come this or next month from as a gift from Italy. This is a prep room. These are offices upstairs. There's a lecture hall. You see, they're just finishing up. And I think that's been built well to try to provide services for this area, but this area serves a population of probably about 8+ million people, so it's obviously one center there is not going to be enough. So I'm just going to show you a couple more slides about what the problem is with chemotherapy in some of these places. So this is Duke's chemo administration protocol. It's 14 pages long on how to administer chemotherapy. Things go wrong. You get the wrong order, the dose might be wrong, and there's all sorts of fail-safe mechanisms that have to be in place to try to figure out what the proper thing to do is, because obviously you don't want to give the wrong dose of chemotherapy or the wrong chemotherapy. Orders can be incomplete. So these aren't theoretical problems. These are real problems that happen a lot. You might have the wrong diluent, the wrong hydration, the wrong hydration fluid. These are all based on weight, and so we calculate a surface area to figure out what the dose is, and the surface area may be wrong. And so there is a lot of nodes to try to figure out when something is properly done or not. And you can imagine places, in certain places in these low to middle income countries, this would be quite a challenge. Not only that, but if this is just a simple algorithm, if you have an older woman here with large cell lymphoma, you have to decide on the goal of therapy. Then you have to think about all the possible dose adjustments that you have to do based on age, gender, performance status, the BMI, the neutrophil count, the platelet count, the cardiac function. And then you decide what chemotherapy to give, what kind of supportive care this patient needs, what kind of other supportive care, and then how you're going to manage these patients. Some of these patients need to come back to get more antiemetics or to get fluids, and so this becomes quite a challenge. But I do think, CFAR has been supportive of many of the research efforts that we've done in East Africa, especially around the area of HIV-associated malignancies. So I think one of the goals, I think what Duke is well positioned for, is to partner with these other stakeholders to figure out how to build some of these cancer systems. These are things which we take for granted because we work in these areas and because there is a lot of infrastructure that has been built around this. And this has been built over time, over cancer care, beginning in the late 60s. And to try to figure out how to move bits and pieces of this to some of these areas is really very important. These analytical models could be applied to any non-communicable disease and to any country. So things that we've learned, for example, by building this in Bugando could be carried over. And I think this cross-disciplinary training of physicians, of these trainees, we have a lot of students, residents, and fellows, and junior faculty quite interested in this area. And so I think gives Duke the ability to catalyze some of these cross-fertilization. So Duke Cancer Institute has expertise, has health services, population science, and outcomes group. Global Health Institute has a tremendous amount of regional experience, epi, economists. They have the master's program, students, and as well as doctoral scholars. We have the Duke Bass Connection, School of Medicine, engineering, public policy, School of Nursing, and then there's the social entrepreneurship and global health. There are lots of different pieces which I think we could tap into to try to build up this infrastructure. So we want to leverage technical experience, support the regional partners, and then I think the idea really is to try to lead with care. Once we actually have a foothold, I think the only way to sustain this is through research. And so I think once we have the ability to do research in these areas and get grant funding for this, that'll be very important. So I'll stop there. Be happy to take questions.
Questions, Colleen?
On one of your very first slides,
Yeah, so actually the first person we have put in there is a Duke faculty member who's a pediatric oncologist in Bugando. So she's there for the year. And I think it's, pediatric oncology is, kids are smaller, but the piece is smaller. There's less cases of pediatric oncology, and the diseases are more treatable. And so we thought that would be actually a really good way to start, to have SOPs and to have treatment algorithms and the ability to care for some of these kids established that way rather than going to the adult population.
Yes.
So I think the model that I think about is the HIV model where, so fortunately not all chemotherapy is this complicated. For example, the use of imatinib for chronic myeloid leukemia is really a single pill. So once you start the medication and you know the patient is tolerating this medicine and isn't having problems, it's really a pill a day. And I think a lot of the targeted therapies that are being developed are these oral medicines which don't require the same level of intense care that the old types of chemotherapy required. So some of these things really would be just oral medications. I think you probably wouldn't be able to give cytotoxic chemotherapies outside of a medical center.
Yes, Melissa.
Yeah, obviously what sort of has meant so much for HIV care globally is PEPFAR and other sort of global campaigns to provide treatment. Do you see any movement in terms of sort of mobilization towards providing global cancer care, or what would it take in terms of the resource and the capacity building?
So I do see a lot of words. You know, the UN had this whole meeting a couple years ago on non-communicable diseases. I guess it was the second time they've ever had a global meeting like that. So there's a lot of awakening of interest. I think there's been a lot of push to try to get, like the Gates Foundation and the Bush Foundation, to at least accept applications on infectious agent, malignancy associated with infectious diseases as a place to start. The big problem with cancer care is that there are at least 5 necessary components which cannot be delivered by one individual. So to have effective cancer care, you need a surgeon to do the biopsy or to take out the tumor. You need an oncologist to think about the therapy. You need a radiation oncologist, somebody who can turn on the machine and give radiation. You need a pathologist, because somebody's going to have to read that slide. And then you need a pharmacist, somebody who knows how to, and then you need a nurse. And so it is a little more difficult than having one individual that can go someplace and do this. You really need to put a team together and have a sufficient infrastructure. So the cost of this is not insignificant. And I think one has to start somewhere and try to build that. The other part with cancer isn't a disease. It's probably a couple hundred diseases. And so when we talk about cancer, it's a little more difficult than an infectious agent, because it's not one process, it's multiple different processes. So I don't see a national or international push. There are a lot of NGOs that have been trying to increase awareness, but it's a slow process.
Okay, thank you, Nelson.